thank you all for coming in and joining us. The Columbian Editorial Board is pleased to welcome representatives from PeaceHealth, and we will, in just a moment, I'll just let you introduce yourselves. And just so you know, we are recording this and videotaping it. We'll post it unedited on our website for the benefit of our readers. And I believe you met the board, and then reporter Marissa Harshman is sitting in, and she might want to touch base with you afterwards. So we'll just start and let you guys introduce yourselves, and then it's nice to have a meeting like this. We've been having candidate meetings, which are more an interview sort, so we can just have
we won't be insulted by that.
A relaxed conversation here talking about healthcare.
Perfect.
So go right ahead.
So I'm Dr. Robin Virgin. I'm a family physician who's been practicing here in Vancouver for, I think, almost 23 years. I currently serve in a number of positions. Most notably, I'm on the Board of Trustees of PeaceHealth Southwest and have been for about 4 years. I currently chair the Quality Committee, and I also serve in leadership for PeaceHealth System, representing PeaceHealth Medical Group. I am the System Medical Director for Primary Care.
She's an amazing doctor, I have to say.
Thank you.
Go. Sean?
So, Sean Gregory, and I am a native of Austin, Texas, like I mentioned earlier, and thrilled to be here. My wife and I made the choice to, for career motivations, to follow a former boss to Florida, from Colorado, though. So my wife, it was about 6 months in, and she said, we've got to get back to the mountains. And I told her, no, we need to do this for at least 3 years. And we are thrilled to get back to faith-based healthcare, and to get back to a beautiful place to live. And we've got 3 elementary school age, I guess now 1 middle schooler. And our motivation for moving here was to get somewhere where we thought we'd want to be for a long time. So that's why we're thrilled to be here, and certainly have had our assumptions for moving here have been affirmed, to say the least.
And how long have you been here?
We moved here on January 22nd and started on February 5th. So 6 months.
So you lived through the worst winter in history.
I lived in the Midwest, so everybody is an apologist about this winter, and I get if you're used to it, how it maybe was bad, but we found it rather mild. So
That's good.
yeah,
That's a first.
yeah. Our the particularly many of our board members that were active in recruiting me kept asking me, are you nervous? Are you still buying a house? We said, yeah, we're building a house. The winter doesn't stop us, and certainly I've never lived somewhere where the summers are as beautiful and inviting as they are here. So,
Great. Well, welcome.
thank you.
Debra?
Well, I'm Debra Carnes. I'm the Director of Communications and Engagement for the Columbian Network, which includes Southwest and St. John and Longview. I guess I'm about week 6 on the job, moving from Seattle, so I'm thrilled to be here and part of the organization. And just thank you again for the opportunity to come in and speak with you.
Well, you're welcome. We're glad you could join us. Let's start with Sean. Since you're fairly new to PeaceHealth, what did you find there? What is the state of the company, and where is it going from here?
Yeah, so I define the time that I got here as the spring season for PeaceHealth. So when any organization goes through leadership changes, it's hard. And I think PeaceHealth going through a few leadership changes at the top. One of my motivations for being here was I did a fair amount of homework. Like your industry, our industry is small, and everybody knows each other. And everybody that I talked to about Liz and what she had done in California was very positive. And what I saw when I got here was very consistent with that, as well as the people that she's put in place to really help PeaceHealth kind of go to the next level and grow and thrive in what we do. So that's been my assumptions for why we chose to be here have been affirmed in many ways. We've got a great team of people. It's nice that the system office is in the same. So my job is to support Clark and Cowlitz County for PeaceHealth. And it's nice having proximity to the system decision makers, so we can collaborate on things together, and it just makes things easier when you're not doing it all by telephone.
So Sean, just to clarify, so you're overseeing the Longview property too?
Correct.
Okay.
So, when we look at our mission is less about the hospitals now and more about the counties, and kind of our job is to support healthcare in each community we serve. So the communities that I support are Cowlitz County and Clark County.
And just to provide some context for the scope of that,
Sure.
how many people do you employ in Clark County?
Deborah, what's that number?
I
Sorry to
think
put
it's
you on
about
the spot.
2,500, but I can get you the exact
And,
if you're looking for the
because
exact
PeaceHealth
number.
is one of the largest.
Well, if
private
you include,
employers.
I think if you include, there's two answers to that. There's the caregiver, the
Right.
provider part of what we do, which is the physician offices and the hospital and the residency program and the home care and hospice. That number is a few thousand, and then there's another 1,000-ish that are at the system office that support
Okay.
billing, quality, HR, all that kind of stuff throughout the Pacific Northwest.
But I can get you the exact number on that.
It's an interesting time to talk about healthcare, obviously. And I'm curious from a direct provider, Robin, what are PeaceHealth's thought about the debate taking place over healthcare? Where should Congress go with this? How has Obamacare affected the people on the front lines?
From the clinician perspective, I think the tactic that PeaceHealth has taken is to really embrace the care transformation that we know needs to happen. We have to change how we deliver care. We're spending way too much, and we're not getting the quality that we need. And so we...
And I'm talking about that, you mean industry-wide?
I would say industry-wide as well as here in Clark County. Healthcare expenditures are through the roof, and we've had a lot of patients that haven't had access or be able to afford healthcare either. And so either way, PeaceHealth is committed to taking care of those patients. It's just we may be paid, one way or another in that. And so, yeah, I think certainly have our ear to the ground as far as where the outcome lays, and we'll have to strategize where we fall in that, whether or not who we partner with going forward, continuing to approach a lot of the other social determinants of health with partnerships within our communities, looking at other groups that are taking care of our Medicaid populations, Medicare populations. We know that here in Clark County, as well as across the country, the Medicare age patients are really rising, and so we'll continue to have a significant challenge recruiting and retaining primary care to be able to take care of those patients. And so I think we are looking at care transformation. How do we deliver care in a more efficient way with the right collection of physicians and PAs and nurse practitioners to get at that?
One thing that we mentioned to Marissa the other day was, for Clark County specifically, going from 50,000 enrollees in Medicaid to 100,000 over a few-year period, the demand for services from those folks greatly outgrew the supply of people that were prepared to do that. And providers in this community responded in different ways to that. Many of the providers in the community felt like they were forced to limit their access to people with Medicaid. To PeaceHealth's credit, we did not. We took a pretty affirmative stance on that and really have tried to be consistently accessible to people regardless of payer source. But that, I would say, has been one of the biggest changes from the Affordable Care Act locally, is really how do you equip a broader group of providers to be prepared for Medicaid. And then now I think with the who knows what's ahead, really sustaining that becomes a big deal. I think the other thing that's changed in the industry for the better is when you make a choice about where you're going to go for care, you have more information today than you did 5-10 years ago. So it's almost like if you look at buying a car, think about 20 years ago when you bought a car, you kind of went to your buddy and asked her which one made the most sense, and it was more relational almost. And now it's very informed. So you hop on Edmunds.com and you know what the parts are, how each one. Healthcare is moving in that direction, which we think is a good thing. Part of what's complex about that for hospitals like Southwest is we are the hub for specialty care, and we take the hardest cases out there, which makes some of those statistics look different because of the complexity. And many people, for instance, that show up at our ED have, in addition to the medical conditions, behavioral conditions, and in that affects things in different ways. And so we're trying to really get our arms around as really the hub for specialty care within Clark County, how we can do that in a way that makes sense, and also with different expectations that people come to health. I think also as there has been shifting personal sensitivity to cost, so as many of our health plans have shifted from X dollars a visit to X percent of the bill, that creates expectation, because when I am more sensitive to the cost, I also am have more opinions when my doctor refers me for a CT scan, or so we're really it's affecting us in different ways.
And you mentioned with the increase in patients, people seeking health care, then in some cases providers have had to limit do you see that changing? Is there going to be an influx of providers to serve a larger population, or has instability in the market prevented that?
So there is a national shortage of primary care physicians. However, there's also acknowledgement that a lot of the work that primary care physicians do, you can have other people do as well. So where we see, and Robin's done a good job of this and across our system of really engaging team-based care, and how do we, utilize more nurse practitioners and care managers and different people that can really provide value within their primaries. I think that's one of the answers. The other thing that we've been trying to do very actively since I've been here is organize providers within the community to figure out what's the solution for Medicaid access in Clark County. So, people from the public sector, the private sector, and actually I think PeaceHealth was very wise to populate our community health board with not only physician leaders like Robin, but also with Dr. Melnick, who runs the public health department, and Andy Silver, who is a leader within helping with the homeless population in Clark County. So we've got some people that I think we've got the right folks together to help solve it, but it's not a quick fix. I came from a county in Florida where our federally qualified health center, which is what CMAR does here, was the largest, most accessible primary care group. Robin's heard this 1,000 times, so she's probably tired of hearing this. But it was our largest, most successful primary care group in town. And
Wow. That's interesting. What county were you from?
Brevard.
Brevard, okay, so north of Miami.
We were eastern central Florida.
Is that Daytona Beach?
No, it's south of Daytona Beach.
Okay.
But what was different is that group went from 25 to 70 providers, and we had a large dental component to that because oral care is a big challenge, and behavioral health was a big component. We had telepsych and all kinds of different things that help patients. We don't have that robust of a network in Clark County, so a lot of that really spills over into the primary care clinics that Robin supports and leads that don't have the resource. They don't have the medication. There's medication assistance programs that Big Pharma supports, other things. So we're trying to figure out how can we create an infrastructure that does have those supportive resources that makes more sense than tapping into the private clinics that don't have as much.
Well, and one other thing we're doing is the residency program in
That's right.
terms of trying to address the primary care physician.
Can you talk
need.
about that for a minute?
Oh, absolutely. Well, and I'll add
Go ahead.
my other piece. So yeah, we actually, I am in the first class of graduating residents from PeaceHealth Southwest, or Family Medicine Southwest Washington, and decided to stay in this community and continue to serve. And so
When was that, by the way?
I graduated in 1998.
Were you the first class?
Yeah.
Wow.
First class to go all the way through. We had a class that started in their
I
second
did
year.
not
but-
know that, Robin.
that
That's
either.
that is really cool.
Yes.
Almost 20 years?
Yeah, exactly. Yeah. So I moved here to do residency and then stayed in the community. So speaking to that, the residency program has really taken a very forward-looking approach in taking care of our underserved population. When, speaking to what you'd said earlier, when other primary care clinics had to back out or limit their access to Medicaid patients, the residency stepped up. We helped do our part to take care of some of the new families coming into the community, newborn care, and they've also been committed to a long time to provide a procedure clinic to patients that have no ability to pay and don't have any access to insurance, to be able to have vasectomies and other types of procedures that they wouldn't have any other access to, and aren't services that they could access through, say, the free clinic. And so, yeah, we've continued to expand on that. In my year, we had 6 residents in each class, and now we have 8 residents in each class. So they've built that. And I would say, I don't have any statistics for you, but the vast majority of the graduates have stayed, I would say, in the Portland Metro, Vancouver area, which was one of the reasons that we did that in the first place. Speaking to what your question as well is, yeah, we're very much committed to growing both primary care and specialty services, especially where there's a real need. And 2 of the big ones, obviously primary care, but another one is behavioral health. I think both Clark and Cowlitz County, as well as, to be honest, our other counties that we serve as part of PeaceHealth, have really found that that is a really important market. It's a commitment that we have to serve the truly underserved in our midst. And so we've really had to kind of step up our recruitment efforts, and we have a whole new strategy around that, and work very close in partnership with the leaders in all of our behavioral health units. I help support a lot of that work as well. And we have a pretty aggressive plan to, look at compensation and those kinds of things. How can we let everyone know what a great place this county is to live in, as well as looking at innovations, telehealth, those kinds of things, which we can help then cross-serve our other communities. So there's a lot of those efforts underway, and we've got quite a robust plan around growth and strategy and development around primary care as well. And we're working in partnership because there's the medical group and the hospitals, and sometimes we have different needs as far as where we want to grow. And so we've also worked very strongly in collaboration to make sure that our goals are similar and that we're working in the same direction.
How does WSU's new medical school affect the supply of residents here in Southwest Washington? I know they'll be visiting on at least a somewhat regular basis because my wife and I signed up to be a host family.
You did?
Oh, fantastic.
So anyway, so we got to go to our big orientation meeting in about a week.
Excellent. Well, I can tell you that I think the executive team met with WSU before they started the new program, so we were aware and absolutely supportive of that as well. We find that in some of our communities, we serve a lot of rural areas, and so that's exceptionally difficult to recruit clinicians to. But what we found, Craig, Alaska, just another plane ride from Ketchikan, where we have 2 clinicians and that's it.
Wow.
Serve a large, very contained population. But that being said, we find that WSU's strategy has been really careful about recruiting students that plan to stay in the Pacific Northwest and to serve rural communities. And so a lot of our goals are very strongly aligned. So I would say we're very supportive of that.
That was actually one of the most encouraging I've learned about that campus and that strategy. Their commitment to really finding people that have staying power within the community is a big deal, particularly as our focus is on primary care. And we see that's really the biggest gap that we've got to fill.
Primary care.
Yep.
That makes sense. Is there any? So I'm sorry, I'm just going to monopolize the conversation.
go right ahead.
Sure.
So I'm interested. So the Medicaid population growth. So it's allowed them to come to maybe the primary clinics and get some preventive care or some routine care. Otherwise, maybe they used to show up at your hospital and they'd be a charity care case. But now I see almost every day there's something new about what the government's going to do to that Medicaid program. How do you build a program to serve these people at the primary care level when you don't know whether the carpet's going to get yanked out?
Well, so our thinking is we cannot design our organizational strategy around government policy. We have got to really do it under the auspices of best service at the lowest cost. Really ownership of our mission, which is affordability and excellence in what we do, and that will be more durable under any of the scenarios. Because the other thing that happened, though, was this is what Marissa and I were talking about the other day, is of the 50,000 people that were added to the rolls, about 2/3 of them did not have insurance, and 1/3 of them were formerly commercially insured. Now they have Medicaid. So what we found is the revenue so we get paid more from Medicaid, generally speaking, than people that don't have insurance.
Right.
And we get paid substantially less from Medicaid than we do with people that are commercially insured. So we found it was kind of a wash financially.
Okay.
So there wasn't really, but what you see is there's more demand in the physician offices and more accessibility for components of that population. And we saw as that happened, more restriction, particularly within the private businesses of who Medicaid patients takes. That's been the biggest challenge for us. Our take, though, is rather than build a huge platform, we think Medicaid is going to be here in one shape or another, and we're advocating that expansion remain. We think that organization. We think it's the right thing for the public, and it's certainly consistent with what we are as a faith-based, not-for-profit health system.
Mm-hmm. So I'm going to speak to that too, because I was just reviewing some of the details, and I can't tell you any of them quite yet. I still probably need to mull on it from the Washington State Medicaid waiver and a lot of that work that's happening right now. And certainly a great deal of that is around behavioral health and behavioral health early intervention, which will affect here at Clark County. So there are some things out there that we know we need to improve on, regardless of, again, where Medicare or Medicaid go to. One is certainly behavioral health is a huge one.
Right.
Other areas are opioid addiction and treatment, which obviously is aligned with behavioral health goals as well. But we know that we have an aging population, and that the highest expenditure are our patients with more than 3 chronic conditions, and those with more than 5, and the medications that go along with it really take up the highest expenditure. And so some of the things that we've done to approach that, so in Vancouver, in my clinic, over the last, say, 5 to 10 years, we have slowly been working to embed behavioral health within the clinic. So we don't have psychiatrists, because that doesn't really make sense, but we have nurse practitioners that can prescribe. We have social workers, so if you identify a patient that's in crisis right there during your visit, you can do a nice warm handoff to them, introduce them, and say, this is a person I think that can really help. I had a patient the other day that was becoming more and more debilitated and needed services to transition them into assisted living. Didn't know even where to go to, and I said, I now have a resource, because that's not something I could do in the past. So we know that those are going to continue to be very important strategies for us to support. I think other terminology out there that kind of describes this as a patient-centered medical home, that we are providing more like RN services, that we can do case management, help patients learn to manage their conditions on their own. So we have LPNs that are specially trained around that, and we've built out a lot of technology around population health for the medical group for us to better track our patients that have diabetes and congestive heart failure and COPD, hypertension, to remind them to come into their visits, and then focus on those highest risk patients. So there's been a lot of effort around that, and that will continue to be where we focus a lot of efforts going forward.
I think too that there's not really a viable business strategy with Medicaid for us. So really it's about how do you help people avoid expensive things. So how do we help you from coming back to the hospital?
Yep.
And whether it's through the clinic that Robin's talking about, or even our home care programs, we've got a very robust, about 470 patients every day we're going to their home, either for hospice or home care in Clark County every day. And how do we make sure those services enable people to be safe at home and not have to go back to the hospital?
Yeah.
Because if they are Medicaid or self-pay, there's a high likelihood it's gonna not be good for them, and it's gonna be expensive for us. So we have gotten more assertive in looking at that. I think historically a lot of hospitals, and this isn't just a PeaceHealth thing, this is a national, is that we were so focused, hospital, like your business is so complicated, it can consume you, and you can really be focused on what happens inside the walls. But when we take more ownership of what happens to patients when they leave, whether that's medication compliance, the average patient that's discharged from a hospital, how many drugs do you think the average patient's on when they get discharged from a hospital?
Yes.
Oh, I'm going to make a good guess here. I'm going to say 12.
You're close. Any other guesses? Depends. We're close to 10. And think about that. How tracking, Robin sees this every day, how the difficulties of just tracking 10 different medications, not 10 pills, but 10 different medications that you're managing. We've all seen it with our loved ones, our parents, our friends.
Yeah.
My wife got her knee replaced in March, and she came home with 6, and we had to make a written list.
Isn't it
of
hard?
What you could have and what time, and et cetera. She's like,
And one of the things that I think within the Pacific Northwest is something that is good for us is most providers are on the same electronic health system, so there is more sharing of information here. However, there still are a lot of patients where Robin and her colleagues see every day where there's drug interactions that aren't helpful. You know, I've talked to a number of physicians that were close to retire. There were a couple of cardiologists that come to mind that were very active cardiologists. They worked in the cath lab, did a ton of procedures, and then the last 2 years they got into the business of helping patients go on medication vacations. And
I've heard of that before.
and the collective toxicity of drugs is not unconcerning, and there's just a lot of stuff like that when we talk about the real needs of how can we make healthcare better. There are simple, actionable solutions that make sense under any legislative mandate or policy thing that we are trying to more actively, and to PeaceHealth's credit, they're put their money where their mouth is. And do things like what Robin was talking about.
Yeah, and I was going to add, there may be the 10 that you're leaving with, but what were the 5 that you stopped when you went into the hospital, and then when do you restart those? So you're right, it's incredibly
Yeah,
complex.
that's more complicated yet, isn't it?
And you might be trying able to figure this out with dementia. I mean, the likelihood is that the greater your number of medications, the greater the likelihood that you've got memory issues. So they're
From the medication.
no, there's
Maybe.
so
Or whether or not you can afford them.
Right. Yeah. We have to watch the in-laws because they're in their mid-80s, and they're starting to
Absolutely.
lose a little bit of their steam
Yeah.
and more drugs and etc. So the father-in-law just had a medication vacation, and he's actually better. It's
Yeah.
very interesting.
you see that with a lot of people that go on hospice as they get off of their medications, they wind up getting better for a period of time.
Yeah.
I had never heard that term before, but that's I think what he had.
Mhm.
So
I was just going to say, I wonder sometimes if, people are overprescribed when because just from experience with family members, 30 pills a day, and it's like, oh, whoa. How do you keep track of that? But that's a whole nother
Robin, do you want to speak to that?
issue.
I can speak to a little bit of that, and I think something that happened naturally and probably a little bit planned is helping us somewhat with that. Because I think part of the challenge has been our electronic health records don't talk to each other. And so I don't know that you went to a cardiologist at a different clinic and you're seeing them for this, and they prescribed you this medication, and I have you on a different antihypertensive. And if they didn't know, how is the patient supposed to know that these are both for high blood pressure? Unless they regularly meet with their pharmacist. And sometimes we don't even know if the pharmacist makes the different recommendations as, whoa, these interact. And so one thing that has happened over the last several years is that, all the big players in our marketplace, Legacy, Providence, OHSU, Vancouver Clinic, and PeaceHealth, we are now all on Epic as our same EHR platform. And they all talk to each other. Now, you sometimes have to go there, so it's retraining us to make sure we're checking for those kinds of things. But that's a very important piece of everything all of us do at every single point where we're touching a patient, is medication reconciliation, knowing what we know, what does the patient know, and how do we make sure that we do know all these things. Down to the point where it gets a little crazy, where I was reconciling cotton balls and things like that from the pharmacy. So it can go a little bit overboard, but I think in the long term it will go a long way to really protecting our patients and helping us have those discussions. What are your real goals, and are you having side effects? In fact, I've been working a lot on how do we reframe things, use shared decision-making tools with patients to find out, about what's most important to you, so that we can guide their health care a little bit better when we're deciding what medications, what are your barriers. And so I don't even ask, I ask, how often do you miss your blood pressure medication? Knowing that it happens, but oftentimes patients don't want to tell us that they're missing. Are you taking all your medications? Not a good question. How often do you miss them? Well, that you're traveling or something happens. So I think also learning how to take into account natural patient behaviors and not just assuming, I think is really important too.
Well, I'd love to hear that everyone's on the same.
Yeah.
That's unique to the Pacific Northwest too.
It
That is not.
really is.
That actually is something it is very unique to the Pacific Northwest that everybody is.
Are
on the
other
same-
areas pursuing that? Because it would seem to be a logical step.
Well, that Epic, now I think about 1/3 of the hospital systems across the United States, and now even pervading around the world, are on that same platform.
So how has that contributed to the opioid epidemic that we hear so much about?
Contributed or
Yes.
or helping? So
Well, is that
What
has,
impact?
has that helped cause the problems that we're seeing? Just a lack of information about medications,
Oh.
people being over medicated, or what has
I
caused?
think a lot of different things have caused it. So, well, I'll just be,
It's a tough question.
I'll be a little vulnerable here. Back when I trained, we really believed that that high doses were safe for patients. We know that that's not the case anymore. So we practiced in a way that was not particularly safe for our patients. And it's come, in fact, I'll joke about this too. It's now all about the evidence. What does the evidence show? And now that we do have EHRs, we can now compare massive amounts of data. Instead of research studies where you've got 75, 100, 200 patients, we can now do studies of 10,000, 50,000 patients. And so we now have a much better idea about what really works, what doesn't work, what harms patients. And so it's required us to have a big culture change. We also used to make sure in the hospitals, we want to make sure that your, pain is 100% controlled, because that's how we get paid, by making our patients satisfied with their care. Whereas I think now that we know the harms that it can cause, and even just the pain medications that we give someone after a surgery can increase their risk, really doing a much better job of setting patients' expectations about, after surgery you're going to hurt. We're going to give you pain medication for a short period of time, and we're going to transition you to these kinds of things. But if these kinds of symptoms are happening, work with us because we want to take care of you. So
That's tough too. With
it's
older
very
people,
tough.
They need to change the mindset of, especially older folks.
Yeah. No, absolutely. And I think, as clinicians, we want to partner with the patients and we want to make them happy. And sometimes having a difficult discussion about, I know that's what you feel you need, but this is, I really care about you and your well-being, and we really need to, address this and work to taper you off your medications and those kinds of things. And so I'll own the culture change piece from the clinician's perspective has contributed. And so to answer your question about the EHR, I think the EHR has helped, to be honest, in some situations, because now we can take a longitudinal look about how many have you taken. We can now look at what's your collective amounts of morphine, because that's kind of how we look at it. What's the total amount you're getting in a day when you may be getting it for this medication and this medication? How can I now look into other records and see, if you come to me the first time and say, hey, I'm on these different medications, I can confirm that and make sure that you've seen the right consultants. And then I think there's a lot of credit that you have to give to the states. Both Oregon and Washington have really robust state registries, so that every time I have a patient come in that's chronically getting medications, we now require our clinicians to, check the state registry so that I know every single person that's prescribing medications for you, and I can have a discussion. Did you know that when you go to your dentist, because you're on chronic medications prescribed through me, that we need to talk about that before you go so that I can put a plan together? So those types of things. So I would tend to think that it's helped.
One thing that the electronic health systems have not helped with is a lot of times the time clinicians spend on computers competes with times that they interact with patients. Yeah. And it's the time where you interact with patients that really influences behavior. And one of our true north focuses is how can we enable our clinicians to spend more time with patients and less time on computers. That is something that we are trying to figure out. How do we really measure the effectiveness of our IT systems that way to make it easy for you to do your job? How can we make it, Robin feel more like she's on Amazon than an MS-DOS program when she's taking care of her. I mean, there's some mixture of the two that what exists today. But that's a big issue for us.
Well, what are you finding? What are the solutions for that?
To give you one example, I worked at a health system where this isn't a PeaceHealth example, but I think it's endemic to the challenges we deal with. where it took our nurses 45 minutes to document every admission that came to their unit. So if I was admitted to the nursing unit, it would take the nurses 45 minutes to get in the computer and really write up everything they had. And when we asked the nurses, and I spent a lot of time doing this, I go to our departments and I say, what can we do to make our hospital a better place for patients and a better place to work? And typically people start telling you the stuff that they do that, like, this isn't helping a patient. And in this case, what they said was our admission profiles make no sense. It could be more efficient. So we had 20 nurses redesign what that did. And what we found is there was a lot of times they were documenting twice. I mean, think about how many times you go to get health care and you get asked the same question multiple times and you're saying, why didn't you already knew that? Some of which we have to for patient safety, but a lot of it we don't have to. And that 45 minutes went to 20 minutes. And you think about that nurse on average, that's 25 minutes she can spend with the patient helping them. And we're trying to find, it's these little, it's high frequency, not, kind of the little stuff makes a big difference collectively. So we're trying to find stuff like that. Are there scanning technologies that we can use that capture information quicker than typing it on the computer? All kinds of different, how can we leverage technology to allow people to spend more time with, because it's on the opposite. So I think Rob's probably the first person to tell you that technology, generally speaking, has competed with patient time more so than enabled more. It gives you access to information, but it doesn't give you the time back to use that information. Yeah. So that is something that we are very interested in being innovative and trying to find ways to do that better, because it's the fundamental flaw of a lot of, including the government regulation on what has to be documented, which is very burdensome. And if you say the physician whose payment for what they do has been cut over the last 10 years, and then now you've got to document in a way that takes more time, well, that time then competes with time convincing somebody, and the hardest conversations we have are about addiction issues. I mean, so all those things kind of compete with each other.
I can maybe add to that from the clinic setting as well, that, and I'll age myself, I had to take a typing class in high school to graduate. Thank goodness I did, because I never could have anticipated how important typing would be to me at this day. And so I can tell you that a lot of clinicians in my generation that never had that kind of requirement have really struggled with how can I be efficient in entering all of this information. So, certainly we have dragon dictation, which is a voice recognition program, or, straight dictation where it gets sent to someone who can type it. But I think there's also some innovative options that we're working on in piloting. We've had a lot of specialties do this, and we're piloting in primary care around scribes, where you have someone, come in who's a good typist. They're typically a medical student, so they have knowledge of, medical terminology, and they can help enter that as well. So we're looking at a lot of those kinds of things, as well as, going to the next level of, dictation systems that understand more, where it can be more interactive, knowing that. But the other thing, too, that's happening is now they've changed typing as a class to keyboarding. And a lot of our new doctors, and APC is our term for nurse practitioners and PAs, advanced practice clinicians, are really good at typing. And so they can get things in much more quickly. And so there's not as much pushback as there was, I think, with some of us that have been in practice a little bit longer, but it's still a barrier. There's still, that's the problem with having a really high-functioning health record. There's a lot of things to click and put in, a lot of reminders. It'll remind me that you need this test in your mammogram and your colonoscopy, and I can look and find a lot of different things, but it takes more time to do that. It can remind me that, this medication, interacts, and your kidney function is now different than it was a year ago, and now I ought to be watching this medication. So there's a lot of safety tools and that really do help us improve patient care, but it comes at a cost. So we have to adapt to that.
So
I feel like we're depressing you.
So I was just going to step back a few minutes in the conversation. So it's interesting that you're providing family care, primary care, all the way through intensive care at a very technology-based hospital. So is this a typical pattern that companies, healthcare companies, are becoming more vertically integrated? And if so, does that create more pressure for them to become larger and find more partners?
So consolidation is very prevalent within healthcare right now, and with mixed success. So if you look at some of the larger systems across the country, they found diseconomies of scale.
Okay.
So it's kind of one of those things where bigger isn't always better. What we've found, and I think that Liz Dunn, our CEO, has been one of the reasons I chose to come to PeaceHealth is I think Liz is very smart in thinking, and our board, of you've got to have line of sight to the value. We want to be good at partnering with everybody that we work with, but bigger isn't always better. For instance, EMR is actually, high fixed cost things. There's certainly benefits to scale, which is actually one of the reasons we did the Quest partnership, was that Quest it's one of the largest laboratories in the nation, and lab is a high fixed cost kind of production, so they can spread that over more, and there's efficiencies with that there really is kind of line of sight value to, and there's technology that's evolving that makes more sense to. But there's other areas where they're not. You look at some of I think that some of the larger systems in the country have really had more financial stress from their consolidation than wins. If you look at one way to look at that is credit downgrades, and most of the credit downgrades have been from systems that have gone through large transactions. Now the vertical integration is a totally different question, and it's had different results. So, many of the stronger health systems across the country have gotten more vertically integrated, which is what we've been talking about, which is really how can I own the health of the patient and be responsible for that and help patients navigate their choices, with an EMR and different things. However, the pure consolidation, there's kind of a mixed track record. It kind of depends on what it is, and organizations over time. So Kaiser has gotten both big and done a good job. And with that size comes challenges too, whether it's workforce challenge, all kinds of things. So we try and be less philosophical and more kind of circumstantial, I guess, about that.
Is PeaceHealth the right size?
I chose to come to PeaceHealth because of the size. We are about a 16,000 person organization, $2.5 billion across 3 states. And we're big enough to have the scale to invest in the state-of-the-art EMR, to invest in things, but we still can move quick. So I can pick up the phone call and say, hey, Mike Dwyer, our system strategy person, we really want to put an outpatient therapy clinic up in Longview, and 2 days later we do it. So we can move at a rapid speed, yet we have the scale to do well. So what you see across the country is a lot of those systems that are in that $2 to $4 billion size seem to be able to be nimble enough to be successful, yet have the scale to do well. And there's different people. You could ask 5 people and they'll give you 5 answers to that question. That's simply my opinion and my experience. And what I think the credit rating stuff might be a more objective representation of that question.
Any idea how many organizations around the country are larger than that? Larger than the 2 to 4 billion? You have to get Marissa to figure that out.
She knows that stuff.
She does. No, that's an
does.
answerable question. I mean, it's a list where we'd probably recognize most of the names. Purely in the hospital and medical group space, there's probably a list of less than 50, more than 20. So it's not huge. That's you think about what we spend nationally on healthcare. It's not a huge number.
Well, let's talk about nationally in healthcare.
Mm-hmm.
What should Congress do to address all of this? What would you recommend?
So one thing that is and has been done that I think is the right thing is transparency. So we have more information on our physicians, our hospitals, our nursing homes, our home care agencies today, and that has driven us to perform. So Robin sits at the chair of our quality committee. She is not nice to me when she sees some stuff that she doesn't like, and that's a good thing. And I think the public too. I think the public's awareness of that is it let the market drive. I think allowing people to access and make informed choices is a great thing that has been done. The other thing that Medicare has changed, this is not Congress, but this is Medicare, is adjusting payments based on performance. So payments for most services paid for by the federal government today are adjusted based on outcomes and customer feedback. Sometimes those things don't mix with each other. So, for instance, when you don't give the person their pain pills, sometimes they don't like. So there's not. It's not a. There is an art and a science to it. So it's not perfect, but I do believe it's directionally better than what existed before that.
It used to be somewhat geography based, didn't it? Because the one thing is that the people here always receive lesser payments than what doctors did in other regions.
There are definitely geographic adjustments for that. And with that, there's still the value-based adjustments, which I think is the right thing. The other issue that is prevalent at the national level to make a decision on is Medicaid, the preservation of Medicaid expansion. We believe that's the right thing for many of the reasons that we talked about today, that if you put somebody in a position where they can access primary care as opposed to an emergency department, that everybody wins.
Is that more cost effective in the long run?
Absolutely. The cost of a primary care visit, depending on where you go for primary care and what hospital you go to for emergency care, is probably 10 to 20 cents on the dollar. And you're not always going to get the same service. So there are some things you're going to show up for the hospital that you're probably going to get that you wouldn't get in the doctor's office because of the proximity of it. But yeah, generally speaking, it is the right thing.
You're not going to know your name at the hospital either.
Yeah, in a lot of times, one thing that we're really focused on is care for the elderly. So a lot of times when somebody that's got memory issues, the environment of care in a hospital can create delirium and other things that really impact that person's health in a negative way. So we believe that finding alternatives in the emergency department is the right thing to do for a bunch of different reasons.
And that requires.
Go ahead. I'm sorry.
Well, and that requires community partnerships. So I was just thinking about that in particular. So creating stronger partnerships with our facilities so that you can do something that we call treat in place, as opposed to, so a demented patient who all of a sudden is having some aggressive behavioral types of things. Oftentimes they just send them to the emergency room because, it could be infection or something else medically. Well, if you can leverage, a team, usually led by a nurse practitioner, to go out and do an evaluation and suggest medications, it's so much more efficient and better care for the patient than bringing them to the emergency room and potentially exposing them to all of those types of things, as well as, like we talked about, the medication reconciliation issues and those kinds of things. Right. And then they stay in a place where people know them. And so I think those are the types of things that are really important for us to continue to partner on.
Yeah, the other piece,
470 of those a day, visits to homes, something like that.
Mm-hmm.
Is that the number you used? Anyway,
that was the number.
So yeah, that's a good.
The other piece is when somebody gets to the hospital, what happens? So there's several things that are important. One is decreasing the time at which people stay at the hospital. So that has been one of our big mantras at Southwest recently, and we've reduced the amount of time people stay at Southwest by 20 hours on average per patient. And that has been a huge thing for us. It's been a huge thing for our patients. The thought is, once Robin says you can go home, we want to get you home. We don't want you to wait 3 or 4 hours to get your paperwork done or whatever else. We're really trying to be more sensitive to people's time.
Now, has that resulted in a reduction of care, or are you still able to provide the same level of
We
care?
have seen our readmissions decrease at the same time our length of stay has reached. So we haven't seen a correlation in people having to come back to the hospital. In fact, we've seen the opposite.
It makes your hospital bigger, doesn't it?
And it gives more people private rooms. So we went from 70% of our patients having a private room to 98% of our patients having a private room. So it helps in a variety of different places. That's been a really big deal for us. The other thing that is incredibly important, and it's part of that equation, and one of the reasons why people get out of the hospital quicker, is getting people mobile and out of bed. So it is not good for anybody to be immobile if they don't have to be. And really getting our caregivers more comfortable with safe patient handling and getting people out of bed and walking around. Particularly, you think about the frail little old lady that shows up on a Friday, and if she's sitting in bed all weekend, there's a good chance she might wind up, not having to go somewhere before she goes back home. So our take is, I want to get you mobile, and I want to get you out quick as soon as we can and do that well. And
Yeah.
we have really tried to place greater emphasis on that and had a fair amount of success doing it.
Yeah, and incremental gains in that area. So you may realize that a piece of it is getting a patient up and walking. Another one might be making sure that, okay, we just happenstance, you're here, because of your pneumonia. Are we making sure that we get you off your oxygen so that when we do get you up and walking, we know that you will do okay, as opposed to keeping that on until the very last minute, until you just go home and then we realize, oh my gosh, you really needed to have your oxygen.
That's a good
So
point.
it's getting ahead and thinking about all the different pieces that will get the patient home safe, as well as making sure that we have the resources to go do home care and physical therapy and a lot of those kinds of things that can be safely provided in the home. Where a patient wouldn't really need to be there, as well as arranging for placement if someone does need to go to a nursing facility, making sure that we have the relationships with the payers and those kinds of things, so that there aren't, I would say, technical reasons that we can't get a patient out sooner.
So Jody, for your 30 pills a day, we also
It
want
wasn't me, but.
we also want you to have a bag and have those pills in your hand before you leave the hospital.
Yeah.
So part of what we want to do is make it easy for people to do the right thing. And medication compliance is a challenge that Robin sees every day, and everybody that we work with is seeing every day. So how can we make it easy for people to do the right thing?
And the pharmacy is working with us on that too, so that patients don't have to go to the pharmacy, and we're sending them home.
We're
with-
trying to deliver your scripts to you in bed before you leave,
That's nice.
versus having to run by Walgreens or whatever else.
It's great.
People said, oh my gosh, waiting rooms, that's great.
Yeah, it's a big deal.
Looking at the legacy system and the PeaceHealth system, any changes in the areas of emphasis serving the same geographic area, that things that are on their way as being more important, or things that are moving away from? Any reshuffling of the deck there?
Probably, Scott, what I can speak to the most is what we're working on together. The issue of primary care access for people with Medicaid is something that we're working on together. That we believe that a community solution makes more sense than either system on their own. We also are working together and talking through behavioral health. It's an area where there's infinite more demand than supply, and are there solutions similar to obviously Portland's done a good job on that with the Unity Center, and is there something that we do that looks different than what we're doing today? I know through the state legislature there was passed a planning grant for behavioral health in Clark County, and that's a community planning grant to figure out how do we do that in a way that makes more sense. In terms of divesting in services, there's nothing that sticks to mind that I see either group. I mean, part of Clark County is we're a growing community, and there's, I probably see more growth for both systems than I would divestment.
Yeah. And also the ability to partner better for services that we solely provide at Southwest, I think, is something that we've also been working on. So, for instance, our cardiovascular intervention program. So, if a patient's actively having a heart attack and they need to go to cath lab, you want to get them to the closest one so that we can open up those arteries just as quickly as we can. So, we have a nice, robust system going back and forth, and I think having open dialogue about how that's going and how we can get patients there faster are also areas that we're discussing. Our stroke program is also top notch. I don't think trauma certainly is as well. So I think about those three in particular that we are just doing very well. And then there are some other areas I think where we've partnered as well that around congestive heart failure. Legacy showed about a year or two ago some just striking, impressive reduction in the readmission rate for patients with congestive heart failure, and they had a checklist, and part of it was that as well, that stopping the oxygen and making sure that they're doing okay, those kinds of things. And so there's a lot of things that we've learned in partnership from what they do well. I
think our intent is to double down on the most complicated core of what we do, which is neuro, trauma, hearts, a lot of time critical diagnoses. It's kind of surprised me that, and it's not, well, I guess it shouldn't be too big of a surprise, because a lot of times when communities get bigger over time and the little community hospital turns into something bigger, folks don't realize that really complex, high-end specialty care is available right in town. And we've got way too many best kept secrets. We've got some physicians that are doing some of the most complex heart rhythm treatments with some of the least amount of radiation in the country at Southwest. And we don't do a good job of making that visible, that says, gosh, if you get your ablation done at Southwest, you'll have 10% of the radiation that you would most other places in the country. So we have got to do a better job, which is why we're thrilled to be talking to you guys today, at telling our story and really getting some pride around some of the unique and pretty state-of-the-art stuff that's available locally. Another thing that's changed within the treatment of stroke care is there are more interventions done now that remove clots versus purely medical treatment, and the indications for that clot removal is broadened, and the recovery time for that procedure is just miraculous. The system I was at when we started doing it, we had this video of a gentleman that had a stroke right before his daughter got married. It was an awful stroke, probably would have been life-changing. He gets his clot removed and he walks her down the aisle the next week. Just stuff like that what could have been nursing home, life-changing, all of a sudden is totally different. Now within communities, one of the things that Bryce and I, my counterpart at Salmon Creek, have talked about, just from a scale standpoint, these are high fixed cost things. You don't need one on every corner. So we've, tried to be collaborative and complement each other's programs where there's an opportunity to do that.
Yeah. I was also thinking maybe some end-to-end care. So some other things that I think are important to understand about kind of the change of our trajectory at PeaceHealth Southwest is, we reformatted, the real focus of our board a number of years ago to really focus on community partnerships as well as quality. And one of the examples of the outcome of our community needs assessment, and a lot of that work had been around focusing on maternity and child care, knowing that we have one of the highest mortality rates in the country for moms around certain diseases that aren't recognized very early, like preeclampsia. And so the program, the Nurse Family Partnership, which we have partnered with the health department here in town to help provide more services, focuses a lot of intensive care to first-time moms that are high risk. And they then do home visits through the first 2 years of that child's life, through the development. And the outcomes of this program that's been in action for over 30 years is just astounding with regard to decreased risk of preeclampsia because it's recognized much sooner. I think depression rates and childhood development and child abuse and all of those kinds of things that are really serious problems for our community, I think, is one area. We've also looked at that and have done a partnership with one of our outside groups around nurse midwifery and providing low-risk care to our Medicaid patients that then follows them all the way through. We've committed to doing, low-risk water births in our community. And then we've also partnered with OHSU to provide neonatal intensive care. And so now we can follow a patient, all the way through, the ones that you would predict might be the highest risk, and make sure that, we can provide top-level care in the community and not separate the mom and the baby, especially if something happens like preterm delivery. And so I think that's a real example of kind of partnering all across a patient's care to provide high quality and what's important to the family, keeping them together.
The other area that y'all haven't asked about, but I know Jody and Scott, we talked about when we met a few months ago, is PeaceHealth's kind of reintegration of the community. So we are setting expectations with our executives at the hospitals that everybody has at least one community board that they participate on. We are also teeing it up with our director level colleagues to give them kind of a list of priority organizations that we think best align with our mission, and asking people to pick something that's really you're passionate about and you think makes sense for PeaceHealth, and to try and kind of have a systematic way to engage people. In my experience, I think probably most of us, is that board experience is also a good leadership experience for folks and to go through, especially if you've ever been on a board of not-for-profit and you've gone through the highs and the lows. You apply that to what you do professionally for good and bad.
That's a great idea. And
that has been something that we are really going to try and do a better job at, is having I mean, I'll certainly, I'm working down that path myself, and Carol has been my kind of partner to help navigate different organizations to work with and be active in. But really encouraging not just the C-suite, but the leadership team, because we are the largest, if not one of the largest employers in the county. And, most of our directors, the average nursing director actually at the hospital has 300 full-time equivalents that work for them. The average director probably has closer to 50, because there's different people that, there's some staff roles that don't have as many people, but they're big jobs, they're big leadership jobs. So giving them that experience, we think is a big deal. And we think it's also a good way to accomplish our community kind of integration and wellness mission too.
Sean, you want to share with us what word you've chosen?
So I can't yet, because Carol is pushing me in a couple of different directions. I don't think we've made that. But my take is I'd rather go deep than wide. I think sometimes when people sit on every board in town, it's not good for the organizations, it's not good for their families and whatever else. So I'd like to pick a couple, and then Amy and I have tried to make the event circuit in a reasonable way that's conducive to our kids and our marriage. But more importantly than me is getting all of our leaders. Really, honestly, as much as, maybe I could double or triple my load, but I prefer that we have our physicians. And that includes medical leadership too. We're really trying to figure out how we can all plug into the community in a more broad way and kind of have more defined expectations for that. So it's not kind of loose, like, hey, this is important, go do it. But Deborah is helping us come up with a list of organizations which we think are most aligned with our mission, and then help teeing that up for folks. So we kind of have a systematic approach to do it, and some expectations that I've seen work really well. Yeah.
Great. Well, thank you very much for joining us today.
Yeah,
Appreciate
it's
it.
great.
Yeah.
Very
Okay,
informative.
thank you.
Yeah.
I enjoyed it.